Hello everyone, welcome to Miss Doc T. This is Dr. Farheen, General Medicine Resident, and today let's discuss a rheumatological topic, polyarteritis nodosa. So this topic is especially important for PG entrance examination. We'll start with a question. A 40-year-old male, known case of hepatitis B, presented with arthralgias, myalgias and hematuria. Skin showed the following lesion. So you can see the picture and renal angiogram was done, and this is the picture which is given. Watch the video till the end. You can easily understand these pictures. Now, what is the diagnosis? So first clue is that this is associated with hepatitis B and it is common in men. It can present with hematuria, and because renal angiogram is done, that means kidneys are especially involved. There is some lesion which is shown in the picture. Okay. Now we'll look at polyarteritis nodosa. So as the name suggests, poly means multiple, arteritis means inflammation of arteries, and nodosa means there are nodular lesions. So polyarteritis nodosa means inflammation of multiple arteries with nodular lesions inside them. So this is a vasculitic syndrome. Now what is a vasculitic syndrome? So two conditions should be present. So first thing is that there should be inflammation of the blood vessel wall leading to decreased blood supply to the tissues. So when these two conditions are present, it is known as a vasculitic syndrome. There are many vasculitic syndromes, of which one is this polyarteritis nodosa. This condition PAN is especially common in middle-aged men, and it is commonly associated with hepatitis B and sometimes also with hepatitis C or hairy cell leukemia. Now let's look at the pathogenesis of PAN. The hepatitis B antigen acts as a trigger against which antibodies are released. Now these two will form immune complexes, and these immune complexes will circulate in the blood vessels, and then they will finally deposit, especially at the branchings and at the bifurcations of small to medium sized arteries. So this point is important to remember. Now once they get deposited, they will elicit an inflammatory reaction. So this inflammation will lead to necrotizing vasculitis, and finally the inflammation heals by collagen deposition. Now this collagen will weaken the blood vessel wall, and that part of the blood vessel wall is prone to develop aneurysms. And these aneurysms are typically less than 1 centimeter in size, and they are known as microaneurysms. So on one side there is inflammation, and because of inflammation there is decreased blood supply to the tissues. And on the other side there is microaneurysm formation which may rupture producing bleed. So decreased blood supply and bleeds are the 2 points to remember in polyarteritis nodosa. Now we'll look at the clinical features. In polyarteritis nodosa, there is multi-system involvement. The first and the foremost organ to be involved is kidney. In the kidney, when there is decreased blood supply, it will lead to renal insufficiency and hypertension. And similarly, when the microaneurysms rupture and produce bleeds, the patient may present with hematuria. So here, remember, there is hematuria without any associated glomerulonephritis in polyarteritis nodosa. So usually hematuria occurs because of glomerulonephritis. But in polyarteritis nodosa, there is hematuria because of ruptured microaneurysms, not because of glomerulonephritis. So first and the foremost organ to be involved is kidney. The second organ to be involved is skin. Now, when there is decreased blood supply to the cutaneous tissues, it leads to livedo reticularis. This means red to purple color lace-like pattern on skin because of obstructed cutaneous vessels. This is the picture. And similarly, obstruction to the end arterioles or the capillaries presents with Raynaud's phenomenon. So this is the picture. Now, when there are microaneurysms in the cutaneous vessels, they may rupture producing bleeds in the skin, and that will present with purpura. The next system to be involved is the gastrointestinal tract and also the genitourinary system, which are rare to be involved. And when these systems are involved, because of decreased blood supply, there is infarct, and infarcts will present with acute abdomen. but this is very rare. The next one is musculoskeletal involvement. So decreased blood supply to the musculoskeletal system presents with arthralgias and myalgias. Similarly, decreased blood supply to the peripheral nerves present with peripheral neuropathy. So this is about the clinical features of PAN. Here a very important point to remember is there is sparing of pulmonary circulation in polyarteritis nodosa. So this is very important to remember, because if the question gives some pulmonary symptoms like hemoptysis or cavitary lesion in the lung or cough, then you can easily rule out polyarteritis nodosa. Now coming to the diagnosis of PAN. First is the biopsy of the involved organ. The second is the arteriography, especially the renal angiogram, which can demonstrate multiple microaneurysms at the branchings and at the bifurcation points. This is the picture. So you can see the renal angio, and especially where the vessel is branching, you can see multiple microaneurysms. Now coming to the treatment, because it is an immune complex mediated disease, immune suppression by a combination of steroids and cyclophosphamide is the treatment given. Prognosis. If it is treated, there is a favorable prognosis, but if left untreated, then PAN has a poor prognosis. Now, what are the points to remember to solve an MCQ? This condition is common in men and it is especially associated with hepatitis B. It produces lesions at the branching and at the bifurcations of vessels. Kidney is the most commonly involved organ and it can present with hematuria because of rupture of microaneurysms. But there is no glomerulonephritis here. The second organ to be involved is skin, and it may present with livedo reticularis or Raynaud's phenomenon or purpura. Then very important to remember is there is sparing of pulmonary circulation. So there will be no complaints like cough, hemoptysis or cavity formation on a chest X-ray. Now the 4 important points to remember include association of hepatitis B, lesions at the branching of blood vessels, involvement of kidney and skin, sparing of pulmonary circulation. Now we'll come back to the question. So you can see now a condition which is associated with hepatitis B, common in middle-aged men, and presenting with arthralgia, myalgia and hematuria. So again there is hematuria, and the renal angio is showing microaneurysms in the picture, and the skin is showing livedo reticularis, that is a lace-like pattern because of obstructed cutaneous blood vessels. So now the diagnosis here is polyarteritis nodosa. Now see, antigen acts as a trigger and leads to vasculitic syndrome in 2 conditions. The first one just we have discussed is polyarteritis nodosa. So can you tell me what is the second condition? I'll give you a clue here. In polyarteritis nodosa, hepatitis B antigen acts as a trigger. So the second condition is commonly associated with hepatitis C antigen. So hepatitis C antigen acts as a trigger and causes another vasculitic syndrome. And if you know the answer, then tell me in the comment section. We'll discuss it in our next video. So that's all for today. Thanks for watching. Hope you liked it. Let's meet again with another new topic. Till then, just take care, be happy and stay safe.